Welcome friends to another lecture on the acid-base homeostasis series. With all this negativity which has been going out because of this COVID, I decided to start all my lectures with some positive thought to make our day better. Stay positive, better days are on its ways. So far what we've learned about the clinical presentation of the acid-base disorders, we've learned the classification of the acid-base disorders, and then we've discussed the various compensatory mechanisms which help the body fight any disturbances in acid-base homeostasis. We discussed in detail the buffer systems. We talked about the bicarbonate buffer system, we talked about the protein buffer system, we talked about hemoglobin as a buffer. Then we discussed the renal compensatory mechanisms. In the renal compensatory mechanisms, we had discussed that there is a sodium hydrogen anti-transport mechanism. We've discussed the process of reclaiming of bicarbonates. We've discussed the process of production of ammonia, and we've also discussed the process of how organic acids are excreted from the kidney. We've also discussed the roles of the respiratory center in regulating acid-base homeostasis. We've talked about the peripheral chemoreceptors and central chemoreceptors and the fact that these are sensitive, one is sensitive to the blood pH and one is sensitive to the CSF pH, and what is its importance in treating acid-base disorders. In case you're not sure with any of these topics, I would request you to go back and see these previous videos. In the present scenario, when a patient reaches us in an emergency department with altered sensorium, the buffer systems have already tried their best. The respiratory and renal compensatory mechanisms already started working. It's only when all these have failed that the patient has come to us. And the starting point is to know something about the blood pH and what is causing the abnormality. So that's when we send a sample for an ABG report. Now this is a ABG analyzer which you generally find in the emergencies, in the ICUs, and also in certain labs. We use a syringe where heparinized blood is taken and fed to the machine. The machine works on electrode principle and gives us the results. So we have to understand the process of sample collection between venous blood gas and arterial blood gas. These are the two things which are commonly asked, arterial blood gas being more commonly asked, but a challenge problematically while collecting the samples because we are dealing with high pressure systems. The difference between the normal values of arterial blood gas and the venous blood gas is something that you should know. pH, not too much of a difference. PCO2, slight difference. Bicarbonates, a slight difference. The PO2, significant difference. These are the important things. So when you're managing a patient and you just want to know the pH status of the patient, VBG and ABG is good enough. However, when you do a complete blood gas profile, you need to know that the PO2 levels of the arterial blood and the venous blood are significantly different. Now, when we feed a sample to the ABG analyzer, few parameters are measured and few parameters are calculated. The measured parameters include the pH, the partial pressure of oxygen, the partial pressure of carbon dioxide, and conventionally most of the arterial blood gas analyzers have electrodes for measuring sodium, potassium, lactate, chloride and glucose. These are all directly measured. The other important parameters of the ABG analysis, which includes the bicarbonate, the base excess or deficit and saturation or oxygen saturation, these are calculated figures. So we have one set of measured parameters and we have one set of calculated parameters. The bicarbonates is calculated based on the partial pressure of carbon dioxide using the Hasselbalch-Henderson equation. So if there is any change in the carbon dioxide, partial pressure of carbon dioxide, it will implicate the values of bicarbonates, and that would have a significant implication in analyzing and interpreting the arterial blood gas results. Sample collection, usually after using sterile aseptic precautions, the radial artery or the femoral artery is punctured for collecting the blood. Now we have proper heparinized syringes which are used for collection of arterial blood gas, and after the sample is collected there is a tight fitting cap which blocks it. The anticoagulant used in a ABG collecting syringe is lithium heparin. but the conventional practice is used to use an insulin syringe, use heparin which is available in the wards and collect the samples. The problem here is that the heparin that is used for treating patients is sodium heparin. So, if you are using sodium heparin collecting blood sample for ABG analysis, the sodium levels will be questionable. The modern syringes have a cap which prevents gaseous exchange. The conventional ones do not have it. So, what was common practice was, after collecting the sample, the needle is bent and this minimizes the exchange of gases. When collecting the sample, be sure to use all aseptic precautions. It should be airtight. There should be no bubbles when you are collecting the sample. Now, remember, we are dealing with gases, we are dealing with very minute volume of blood. So, if there is a little bit of gas, the atmospheric carbon dioxide and the atmospheric oxygen will mix up with the air, with the blood sample, and vitiate the reports. Now, the test should be done as early as possible because gases escape and the pH changes. I have done this experiment in my lab where I collected a sample and tested it in 10, 20 and 30 minutes, and we found out that if a sample of a patient who was severely acidotic, in 30 minutes the results became normal. So, it is important to ensure that the test is done immediately. Now, here is a very interesting concept. We collect the sample. As doctors, we know the importance of an ABG. We collect the sample and we say get the result done. But during this process, the sample is collected, the nursing office, the nurse attends to all the other requirement, finds the ward boy to send the sample for the test. In the chamber where the analyzer is present, maybe the technician using the analyzer is not available. So, a frantic call is made to him to come to done the test. He comes and does the test. This all is the one that contributes to the 30 minutes. You ask a doctor, he says the report should be done immediately. But is the result actually being done immediately? He doesn't know. Gets a result and starts managing the patient. These are called pre-analytical errors, which we should be very careful about. And there's also another important pre-analytical error which I told you, whether we are using lithium heparin or we are using sodium heparin. If your heparin has already got sodium, then the sodium values you get on this sample will not be a true reflection of the sodium levels of the patient. Now, there's another interesting concept which I need to talk to you about. Most of the devices that are used to measure the pH, the sodium, the potassium are electrode based. The principle and working of an electrode, I have covered it in a video and I'll give the link below. But there are two things which you should understand. One is a direct ion sensitive electrode and an indirect ion sensitive electrode. Now, in an indirect ion sensitive electrode, we take the sample, we dilute it with a diluent, and then the readings are taken in this place. This membrane is sensitive to the particular ion of interest and we get readings over here. This is indirect. Most of the pH electrodes use this principle. Whereas, direct ion sensitive electrode, here there is no pre-dilution. The sample is directly loaded onto the electrode and the readings are taken. We should understand certain concepts which is called matrix exclusion effect. In indirect ion sensitive electrode, if the proteins are high, if there is leukocytosis, if there is hyperproteinemia, then because of a concept called matrix exclusion effect, the readings that we get from these samples will be slightly lower than what it actually is. Matrix exclusion effect does not occur in direct ion sensitive electrodes. Most of the laboratory electrodes work on indirect ion sensitive electrode principle. The ABG works on a direct ion sensitive electrode principle. So, when there is a discrepancy of the electrolyte levels between the ABG and that of the lab, please understand, lab is working on ISE, indirect ion sensitive electrode, and the ABG is working on direct ion sensitive electrode. So, the two will usually not sing similar values. The trends will be similar, the values may not be similar. This is something we need to understand. Another common report is that most of the people, the ABG analyzer gets calibrated frequently, and if the equipment does not pass the calibration, it does not take a sample for testing. So, when you get an ABG report and you're not satisfied with the ABG report, understand that the problem is with the process of sample collection and not the analyzers. What are the common pre-analyticals that occur? While collecting the sample, if the sample is not tested immediately, if there is a delay in the sample testing, surely you are going to get an erroneous report. If you are using sodium heparin for collecting an ABG sample, you are going to get an abnormal report. If while collecting the sample there are small air bubbles which you have not completely evacuated when you are heparinizing the syringe, then also you are going to get errors. Then we also have to understand the concept of direct and indirect ISC, which I discussed. A general word of caution, this is something which I have heard from most of the clinicians, is why is pre-analytical important for me? This is more of the lab domain. If I find a result which is abnormal, then I just repeat the test, I get a normal value and I do the test. So this is where clinicians are not paying attention to pre-analyticals. Yes, I do agree to the fact that a sample can be repeated and you can get an actionable report. But a pre-analytical error is also selling a message that the hands which are incapable of collecting a sample for doing ABG, how could you be confident that the same hands deliver good treatment? If they have demonstrated their inefficiency in collecting a sample, how do you expect these hands to be efficient while managing the patients for which you do not have any methods to find out? So, a pre-analytical error is a signature that the patient is not in safe hands, and that is why you and me, both of us, have to be very cautious and very concerned about pre-analytical errors. So, we have discussed in this lecture about how to collect the samples. We have discussed the differences between arterial blood gas and venous blood gas and what are the normal values for each. We have discussed what are measured parameters and what are calculated parameters. We have discussed what are the common pre-analytical errors. We have discussed about dry chemistry, about direct ion sensitive electrode and indirect ion sensitive electrode and the implications in the management. In the next video, we will go on to finding out what are the parameters that come in an ABG report and how do we interpret an ABG report. You can contact me at my email IDs. Constructive criticisms are welcome. In case you want me to make a video on a particular topic, please request. As and when possible, I will oblige you in making those videos. Thank you.